Welcome to this webinar on sleep disturbances in menopause. I am Angelica Hirschberg. I am gynecologist and professor at Karolinska Institutet and Karolinska University Hospital in Stockholm, Sweden. And I was the past president of EMAS. And now I have the pleasure to be the chair of this webinar. And today we have two speakers. We have Professor Päivi Polo-Kantola, and we have Professor Pauline Maki. And I will start to introduce the first speaker. And I would just like to remind you that you are very welcome to ask questions and use the Q&A function. So the first speaker is Päivi Polo-Kantola, Professor of Obstetrics and Gynecology at University of Turku, Finland, and also head of the Department of Gynecology at Turku University Central Hospital. And she is a recognized researcher in sleep disturbances during menopause, which we will hear more about. So thank you, Päivi. You're welcome to start.
Good. Okay, as Angelica Hirschberg introduced me, I am working here in Turku, in Finland. We are a small country here in very north of Europe, but we are very keen on female sleep, also especially during menopause. So these are my disclosures. And the next one. In this presentation, we will talk about how can we measure sleep and what are the alterations during menopause, as well as the reasons for menopausal sleep disturbances. Sleep is important. Sleep is important since we use for sleeping around 8 hours per day. In annual level, it means 2,920 hours, and that is quite a lot time. Sleep is important and it is important because it can lead to sleep loss. The most important reasons for sleep loss are different insomnia symptoms, nocturnal breathing problems, and movement disorders. They typically lead to tiredness, decreased cognitive function, mood symptoms, and accidents. But sleep loss has also effect on physical health, to obesity, diabetes, cardiovascular diseases, and immune defense, which are connected with, for instance, malignancies. How do we measure sleep? Mainly, we have two possibilities. We can measure or assess subjective sleep quality, subjective sleep disorders by questionnaires or diary about sleep quality. This assessment covers over a longer period of time. The other possibility is to measure sleep by objective measurements like polysomnography. We talk then about sleep architecture. The difference with the subjectively measured sleep quality and objectively measured sleep quality is that polysomnography or actigraphy They measure typically only one night or some nights. Here you can see the typical hypnogram, which sees non-REM sleep and REM sleep, which are coming in cycles. Non-REM sleep first, and then REM sleep, which increased towards the end of the sleep. Typically, there are 3 to 5 cycles. The problem in sleep studies are, you can press the button now, is the misperception between subjective and objectively measured sleep architecture. That means that the person who has subjective sleep problems may not have any detect sign of failure in sleep architecture, and vice versa. You can go to the next slide and further. Previous literature agrees that menopause and climacteric era deteriorates subjective sleep quality. Compared to premenopausal women, perimenopausal and postmenopausal women are 1.2 to even 1.6 times more likely to report subjective sleep problems. In our own study 10 years ago, though it was a small study, we found that premenopausal women self-reported more. Postmenopausal women self-reported more sleep problems compared to premenopausal women, but interestingly, the difference was more pronounced during workdays than during leisure days. These all women were working women. As for menopause and sleep architecture, the literature is contradictory. In some studies, no differences in sleep architecture between pre- and postmenopausal women have been detected, and in some postmenopausal women have shown to have even more slow wave sleep, that means deep sleep, than premenopausal women. In one hand, one could consider that the high amount of slow wave sleep is a mark of a good sleep, but one can also interpret that it is a sign that postmenopausal women have a higher sleep loss or sleep deprivation, which they when they compensate with a higher amount of deep sleep. What are the reasons behind sleep disturbances during menopause? Can you press the button, please? The most important reason is vasomotor symptoms. And you can go further. You can go further in the next slide. This is a large study from SWAN study, and please press the button so that we can see that compared those women without vasomotor symptoms, those who have vasomotor symptoms less frequently, that means less than in 6 days per 2 weeks, there were increased probability to have insomnia symptoms, and even when women had frequent vasomotor symptoms, that means 6 to 14 days per 2 weeks, that means every day, they were really in high risk to have insomnia symptoms, trouble for falling asleep, nocturnal awakenings, and too early morning awakenings without being able to sleep again. You can continue with the slides. And still. What about objectively measured sleep quality? These are hypnograms from our own study. The upper hypnogram is a perimenopausal woman. She has quite nice sleep cycles there, some awakenings still, yes, but she sleeps quite well. The lower hypnogram is the same woman 5 years later when she has entered menopause. You can see there also slow wave sleep and REM sleep, this red one, but there are frequent awakenings which fragmentate the sleep, and that's why typically sleep is not refreshing. The next slide, please. This is very old study, but it shows so nicely how vasomotor symptoms disturb sleep. Hypnogram there at the upper panel and skin temperature. The woman was instructed to press a button when she woke as vasomotor symptoms, and when you look the skin temperature, those vasomotor symptoms or higher skin temperature co-accident or co-occur with the awakenings. Thus, we can easily understand that the vasomotor symptoms disturb our sleep. Next one. Then the next important reason is depressive symptom. If you press the button, please. And then the next slide. In this study, which included almost 10,000 women, the aim of the study was to evaluate the most important factors to induce mood symptoms during menopausal era. Please press the button. Menopausal status was not so important. Only early perimenopause increased mental symptoms, but late perimenopause or postmenopausal was not significant. From lifestyle, smoking, and from socioeconomical status, poor social support, less than 5 close friends, and hard economical situation were important. About general health, the poorer, the more psychological distress. And then if you press the button. But the most important factors were occurrence of climacteric symptoms, vasomotor symptoms, and sleep disturbances. Then you can press the buttons again. We have to keep in mind that during menopausal era, so many things occur. Aging is very important factor to affect sleep. And if you press the buttons, comorbidity and work and psychosocial factors and socio-economical factors are important. One thing is, after all, to keep in mind that also women have sleep disorders. Most important of them are sleep disordered breathing and restless legs. Next slide, please. Here are the figures of sleep disordered breathing. At the left side, we have the normal picture how the air should be going when we are sleeping. The airways are open, but in airways obstruction, they are blocked, and so there are either partial or total air obstruction. Next slide, please. There are differences in females and males concerning sleep disordered breathing. If you press the button, here you can see that frank apneas are more important in males. But if you press the button, we see that partial upper airway obstruction, which means that there are no frank apneas, but there's all the time resistance to breathe, are much more often in females. We must not consider that this disease is lighter or not so to say, dangerous, but it leads to same complications like to cardiovascular diseases as real sleep apnea. And what important is that symptoms of menopause and symptoms of sleep-related breathing disorders resemble each other in both sexes. Those are vasomotor symptoms, mood symptoms, and also decreased libido and nocturia. And women exhibit these symptoms with lower apnea-hypopnea levels than men. That's why they are many times undiagnosed. The typical symptoms of sleep disordered breathing is snoring. As a conclusion, we can say that sleep disturbances are common during menopause, and climacteric symptoms, particularly hot flushes and sweating, they are key contributions to sleep disturbances during menopause. In addition, mood symptoms and sleep disordered breathing are common and should also be considered. However, the reasons behind are also multifactorial, and therefore a comprehensive evaluation of underlying causes with sufficient time in an appointment is crucial. I thank you.
Thank you very much, Päivi. We will wait with questions until the end of the session. So now we move on to the next speaker, which is Pauline Maki, a professor of psychiatry, psychology, and obstetrics and gynecology at University of Illinois, United States. And she is also director of women's mental health research. Professor Pauline Maki is a leading researcher in the role of sex steroid hormones on cognition, mood, brain function, and stress in women. And the title of her presentation now is Challenges and New Perspectives on Treatment. Please, Pauline.
Thank you. Hello, everyone from Chicago, Illinois. It's an honor to be presenting here today. Here are my disclosures. There are multiple strategies for managing sleep disturbance in menopausal women. You hear this from your patients. Some are trying complementary and alternative medicine, others hypnotics, exercise, managing sleep apnea, as Professor Polo-Kantola mentioned, melatonin, sleep hygiene, and critically important, cognitive behavioral therapy for insomnia. Currently, no dedicated universal guidelines exist for managing insomnia in menopausal women, despite a distinct etiology and a clear unmet need. When you approach your patients to discuss sleep-related issues, treatment is optimized through shared decision-making within the context in which you practice. There are patient-specific factors, recognizing individual differences in symptoms, such as mood and vasomotor symptoms, and comorbidity, mental health, for example, and lifestyle factors. It's important that we rely on Sleep Society guidelines to best inform treatment discussions and share that information with patients. Identifying barriers to sleep is really important. These include health literacy, patients' knowledge about sleep, and even this knowledge about sleep we will see plays into some of the treatments for sleep disorders in this population, and the goal to not be prescriptive given the doctor-patient power imbalance. There are strategies that fit better into some contexts rather than others, and there are cultural nuances to what's acceptable and what isn't acceptable. So it's important to customize the care plans for each woman, ensuring that your decisions align with her circumstances. So broadly, we want an individualized multimodal strategy for sleep disturbances for insomnia. We want to tailor this for the symptom profile, the health risk factors, the preferences, and as we will discuss briefly today, we want to combine lifestyle modifications, evidence-based psychotherapies, and selective use of medications as appropriate. Let's begin with non-pharmacological treatments because they are the gold standard. So menopause management guidelines and sleep societies recommend cognitive behavioral therapy for insomnia as the first-line treatment for insomnia treatments. So this is consistently recommended by the Menopause Society, ACOG, EMAS, the NICE guidelines, and the British Menopause Society. As mentioned in the previous discussion, menopausal hormone therapy is considered the gold standard when vasomotor symptoms are a major contributor. We will contextualize that with some additional data later on. Non-hormonal options are a very good option, especially SSRIs, when women have mental health issues and when menopausal hormone therapy is not preferred, and the new neurokinin receptor antagonists play an important role there. We also need to recognize that we have to urge caution in treating our patients with pharmacological insomnia-targeted treatments like benzodiazepines and Z drugs due to known side effects and risk. So why non-pharmacological interventions? Well, again, they are the first-line treatment. Importantly, they avoid medication side effects, and they're suitable for individuals with comorbidities. Meta-analyses confirm improvements in sleep quality, insomnia severity, and in fact, from a statistical point of view, the effect size is a full standard deviation for cognitive behavioral therapy for insomnia. So the effect is very large. It's the gold standard with robust evidence generally and importantly in menopausal women. This is demonstrated through randomized controlled clinical trials with benefits lasting as long as 6 months in the follow-up. It can be challenging to get CBTI, but evidence shows that it's as effective if you use it online or with self-help formats as it is face-to-face. And CBTI, which we'll go into the components of, has been shown to be more effective than just sleep hygiene or exercise alone. It also has been shown to have effects that generalize to other symptoms, including decreasing vasomotor symptom-related distress and improving mood. I want to go in very briefly to the minimal characteristics of the standard cognitive behavioral therapy protocol for effective insomnia treatment. And there's an online guide for this. The main constituent parts of CBT are at least one effective behavioral therapeutic and one effective cognitive therapeutic, in combination, if one so desires, with effective relaxation techniques, sleep education, and sleep hygiene. Many of us hear about CBTI, but we're not familiar with the active ingredients or its mechanism of action. So I'm going to briefly describe what those active ingredients are. The behavioral therapeutic can be stimulus control, sleep restriction, or both. So for stimulus control, the idea is to associate the bed with sleep. So only go to bed when you feel sleepy, only use the bed for sleep and sexual activity. If you cannot fall asleep, you get up out of bed for at least 15 minutes, you go to a dimly lit area, you do something relaxing. When you feel sleepy, you go back to bed again. You maintain a fixed rise time each morning and you avoid naps. These are general hints or recommendations for your patients as well. What about sleep restriction, that second behavioral therapeutic? Well, this is a very prescriptive approach. You ask your patients for a week or so to use a sleep log to track their wake-sleep cycles. They determine the time that they usually awake and the number of hours that they sleep. So let's take an example. Let's say that if one normally rises at 6 a.m. and you sleep 5.5 hours, then your bedtime should be 12:30. So you go to bed at your new prescribed time. I always go to bed at 12:30. And if that doesn't work, you repeat the prior steps. When you succeed in sleeping in that new sleep restricted time, you can reduce your time and in bed, and when your bed is filled mostly with sleep, you hold that pattern, you keep it going, and then you increase your sleep time in bed. So you gradually try to add 15 minutes to your sleep time, and you do that as a way of relearning how to sleep in your bed. Now, the second active component, and these again are strategies that you can share with your patients, are cognitive therapeutic strategies. Cognitive control, think about this as a data dump. So it helps with mental preparation for bed. So for example, you can write down the next day to-dos on a notebook. You can describe any anxieties, that kind of thing, and you get it out of your brain on the side to prepare you to sleep. Imagery training is to go to a favorite relaxing place and to really immerse yourself mentally in that, smell the smells, see the sound, see what's in your environment and hear the sounds. There's a technique called paradoxical intention, which actually helps sleep by preventing you to sleep. So for example, instructing your patients when your eyelids feel like they want to close, resist that gently and keep them open. And then finally, cognitive restructuring. And this is where beliefs about sleep interfere with your ability to sleep. So for example, and I hear this in my daughter who's a teenager, I'm never going to sleep. That's a common belief that actually perpetuates wakefulness. Well, the idea is that you change that cognition, you restructure it to say, I always get at least some sleep. So these are the cognitive therapeutic strategies. And you're all aware of sleep hygiene, techniques like avoiding excessive alcohol, exercising regularly but not before bed, choosing a bedtime snack that won't disrupt your sleep, peanut butter and high protein content foods are helpful for this, using comfortable, inviting bedding, having a ritual that tells your body and your mind that you're getting ready to sleep, controlling temperature, blocking out noise and eliminating your cell phone and light, etc. Okay, now your patients very often will use over-the-counter non-prescription therapies that claim to assist with sleep. And 2/3 of midlife women with bothersome symptoms are in fact doing this. Black cohosh has been shown in RCTs to improve sleep disturbances, but the data aren't always reliable, so most guidelines don't recommend it. Evidence for other products is too limited to draw conclusions. So the European Insomnia Guidelines recommend CBTI as a first-line therapy, just like the menopause societies do. However, if CBTI is ineffective, pharmacotherapy can be considered as an adjunct or second-line therapy. I'll draw your attention to the bottom right-hand corner of this to note that these guidelines say to only use benzodiazepine and Z drugs for the short term, less than 4 weeks. If one is looking for longer term solutions, you decide this on an individual basis. The first line recommendations for that are the orexinogenic antagonists like daridorexant or melatonin, particularly if one is over age 55 when benzos and Z drugs are not recommended. So let's go into some of those pharmacological treatments, and let's start with hormone therapy. I want to chat with you a bit about hormone therapy and the logic behind using this to advance sleep and to promote sleep in women. So if we look at the 2008 study from the study of women's health across the nation, following more than 3,405 women, we look at the longitudinal findings. And we see that there are 3 characteristic main categories of sleep that worsen as women transition from the premenopause to the early peri to the late peri and post, with the worst effects in surgery. Where you see the icon with the temperature setting, that means that one of the strongest predictors was hot flashes. So you see hot flashes contribute to trouble falling asleep, waking up early, and the total amount of time we spend awake. You'll see that hormonally, decreasing levels of estradiol and increasing levels of follicle stimulating hormone are associated with the characteristic, the typical sleep complaint, which is awakening. So you'll see that up to 40% of women in the late perimenopause and postmenopause complain of this, compared to about 20% of the other symptoms. So this wakefulness is really key to the types of symptoms that women experience. Now, we do know that hot flashes are associated with sleep disruption. In this study by Rebecca Thurston, women wore ambulatory skin conductance monitors to measure hot flashes objectively. And what we're looking at here at 0 is the onset of the hot flash. And then around that, you see awakenings measured through actigraphy. So you see that typically, women awake immediately before or within a few minutes after a hot flash onset. And these wake episodes are concurrent with 78% of objective hot flashes. Interesting. So this supports this contention that in time, hot flashes at night are associated with awakenings. You might think then that most of the awakenings in midlife women during sleep are due to hot flashes, but interestingly, that's not the case. If we look at this beautiful study by Fiona Baker, what she did is she looked at 34 perimenopausal women, and what we're looking at here is each of those 34 participants. So you see participant 1 to 34 on the bottom there, and you see the number of hot flashes they have. Above, you see the total amount of wakefulness after sleep onset for that particular person, measured via polysomnography. Now you see the first 3 participants had a lot of time awake. The second one was awake for more than 100 minutes, but actually had no hot flashes. The hot flashes are indicated by the green. So you see here in this nice representation, your patients, some of them are waking because of hot flashes. Some are waking up even though they have no hot flashes. So indeed, most of the time that women are awake at night is not related to the hot flash. Only 27% of the objective wakefulness after sleep onset occurs in tandem with the hot flash. So, logically, hormone therapy can help with the hot flash associated awakenings, but not with the other awakenings necessarily. So, key recommendations are that menopausal hormone therapy improves sleep in women with hot flashes, but does not improve sleep in midlife women more generally. In perimenopause, transdermal estradiol may improve sleep quality. There's randomized trial evidence, perhaps by lowering the variability of those hormonal changes and promoting more predictable hormone levels. And this is beyond its effects on vasomotor symptoms. There is evidence that micronized progesterone taken before bedtime improves sleep outcomes. 300 milligrams, for example, has been tried. But again, A-level evidence, CBTI is the way to go. We have a new class of medications that offers women sleep benefits, and these are the neurokinin-targeted therapies. If you look at self-reported sleep, fezolinetant, which is an NK3 antagonist, has shown efficacy in improving sleep in Skylight 1 and Skylight 4 trials. Skylight 2 missed statistical significance. A pooled analysis of Skylight 1 plus 2 showed significant effects. Elinzanetant is a dual NK3, NK1 antagonist. The NK1 acts on substance P, which is known to be involved in sleep cycles. Here, the benefits on sleep are highly reliable. They occurred across each of 4 trials, including benefits to women with breast cancer. These effects were immediately apparent, meaning within 1 week. So, it could be that this NK1 receptor antagonist offers additional benefits because of its effects on substance P. Substance P is known to be involved in sleep and to play a role in regulating sleep-wake cycles. Now, what about sleep medicines? It's interesting that if you look at sleep medicine societies, they actually counter this idea that you should be prescribing pharmacotherapies. So they suggest the use of combination treatment with CBTI plus insomnia medication, that is better than insomnia medication alone. In other words, CBTI is the answer. Similarly, they suggest against the use of combination treatment of CBTI plus insomnia medication over CBTI alone. So again, at the forefront, CBTI is the way to go. Benzos are used ubiquitously, and they do benefit sleep. However, they are only recommended for short-term use due to risks of dependence, and long-term efficacy is unproven and should be used with caution in older women, particularly because of increased risk for falls, fracture, cognitive impairment, as demonstrated by meta-analyses, and they have other side effects, headaches, dizziness, daytime drowsiness. Antidepressants for women, particularly with mood disorders or mood symptoms, can be beneficial, and they do have their side effects too: sedation, weight gain, and anticholinergic effects. The first line recommended treatment by sleep societies is often the orexin receptor antagonist, eridarectin. This blocks orexin. Orexin sends a keep keep awake signal to our brain, and so this blocks that signal, in this case at OXR1 and OXR2. And it's been demonstrated in a recent publication in Maturitas in a sub-analysis of 117 women who were menopausal and participated in a larger trial to be effective. It was well tolerated with no increased risk of next morning sleepiness or somnolence, with a few side effects. Gabapentin is helpful. It improves sleep quality and reduces vasomotor symptoms, but has side effects that many women find troublesome. So the integrated strategy to end is to evaluate in the context of menopause, identify causes, contributing factors, get multidisciplinary input where available, particularly sleep medicine for women who complain of snoring, for example. CBTI is the way to go. Find out how to get it in your country. If it's not available through a therapist, it's fine to use an online treatment. Those are also evidence-based. Address the menopausal symptoms with menopausal hormone therapy or neurokinin-targeted therapies in women with VMS, given the role of wakefulness. Antidepressants may also be considered. And to follow up with adjunctive therapies and adjustments as needed, again, with the dual receptor orexin antagonist as the preferred one. Thank you for your attention.
Thank you very much, Professor Pauline Maki, for an excellent presentation. And now we have time for questions. And we have some interesting questions here. So I start with the first one. What matters the most, the duration of the sleep or the quality of sleep? Still not clear to me. Who wants to
I can take
start? Yeah.
I can take that from a cognitive perspective. It's actually work that I've done and work that others have done. And we know that sleep is essential for healthy cognitive aging. And I think that's underappreciated. And studies have actually looked at total sleep time versus what we call sleep efficiency. Sleep efficiency is very simply the amount of time you are sleeping when you want to be sleeping. If that's more than 85%, you're thought to have really good sleep efficiency. And that much more than the total time sleeping is related to cognitive performance, Alzheimer's disease biomarkers, and neuroimaging outcomes. So sleep quality more than time for many outcomes is what we're working for. And that can provide a lot of reassurance to your patients because they feel like they've failed if they haven't slept 7 or 8 hours. So even sharing with them its quality, not quantity, can be beneficial.
And how do you know that you have good sleep quality? How do you know that? Päivi, would you like to comment?
Yeah, I agree that the quality is much more important because we are chronobiologically, we are very difficult or different as sleep duration. Some are short sleepers, some are long sleepers, and that is because of our genetic clock, and we can't totally learn to be morning types or evening times. Most of the people are intermediate, so and then they adapt to the society quite well. But about the reason why the quality is important, that if the sleep is fragmented, that is, I think, the main thing, when the sleep cycles do not take place. So the sleep is not refreshing. So you can sleep total time of the sleep, if you look, sleep architecture is long. But if it is fragmented and sleep circles do not fulfill or do not take place, that is essential that you are tired or your ability to work or perform in the next day is diminished.
Please, if you have questions, please write it in the Q&A area. And here we have, I think, a common question. Have you good strategies to manage restless legs? What do you recommend here?
There can be, of course, non-medical treatments, but if you really first you have to look after the iron, sufficient iron. From this is one of the to measure folate and ferritin levels is not very good idea, but in to detect iron deficiency, that is the main thing to see if you have it, and iron is the main thing to improve. But of course, after menopause, when we don't have periods, for instance, the iron deficiency is very seldom if we don't have any basic disease. So then pramipexole, or even sometimes gabapentin can be good, and for somebody one have to give even some Parkinson treatment, but those are the first line, gabapentin and pramipexole, and these are the field of the neurologists who will treat them.
Pauline, would you like to comment on this?
That aligns very well with the European sleep guidelines.
Okay, so we can move on to another question. Here's one question. I see a lot of women with sleep disturbances affecting their job as well as their daily life, face-to-face. Face-to-face therapy is very rare. Can you recommend a digital health app or a self-training program?
I can tell you which ones we use in the US for English speakers, and then maybe Päivi has one for Europe. But you can Google VA, or Veterans Administration, and CBTI in the United States. At least you could for a while. We'll see if it's still up. But at any rate, it's freely available. And again, you want to look for the ones that have the behavioral content and that have the cognitive content, but there are many out there.
Yes, nowadays there are a lot of net therapy, and it is very effective if you commit on it, and if the therapist is trained. So of course there are group therapy too, but so I think nowadays this net has increased the possibilities in this field.
And here's one question directed to Professor Pauline. Some studies suggest that during the menopausal transition, the brain may undergo a bioenergetic shift with reduced cerebral glucose metabolism and increased reliance on alternative substrates such as ketone bodies. Could this metabolic shift be associated with high prevalence of insomnia during the menopausal transition?
Yeah, thank you for the question. So there's a lot of basic science work supporting that in animal models of ovariectomy, and there's some cross-sectional studies supporting that idea, but a definitive test of the bioenergetic hypothesis really is in a longitudinal study where you follow the same woman from pre to peri to post-menopause. So I think it's a valuable hypothesis, but I don't accept it as being demonstrated in any way yet. So I think what's happening can be informed from the demonstrations from Ellen Zenitant of benefits, reliable benefits to sleep, that there's very likely a remodeling of the neurokinin system, particularly NK1 and the role of substance P during the menopause transition. After all, this involves KNDy neurons, which are the source of the vasomotor symptom. And I think this is an exciting new avenue in sleep research because it begins to tell us what might be the unique underlying etiology of sleep. So rather than kind of default to some global hypothesis about energy systems, I think targeting what we know about the neurobiology of sleep, the role of substance P and the like, may be more what we find in the future to be the basis of menopause-related sleep disorder.
And here's another question maybe related to this one. Hunger and protein cravings are much stronger in perimenopause and probably meaningful in relation to sleep. Would you like to comment on this?
There is recommendations from nutritional guidelines to ingest peanut butter. I know the rest of the world doesn't like peanut butter, so there you go. But a yogurt or a cheese or some high protein food prior to bedtime to assist in sleep. So it is a recommendation that nutritionists will make routinely. And I thank the audience for asking that question. I don't know, Päivi, if you have any additional comments about that.
No, I know I don't have any additional knowledge about that, but it's understandable that at least the food should be lighter, not that when you go to sleep, and so one understand that proteins are lighter than some fat thing or so. So we have to keep in mind that, for instance, chocolate and cacao, it can be very refreshing, and you shouldn't use those before sleeping, and so that is also one issue.
Yeah, and avoiding night eating, avoiding getting in the habit of night eating is really important because your body can start to learn to crave. It's surprising how often we're seeing night eating as a sleep disruptor, particularly in women who are anxious. So they'll get up with this kind of compulsive eating. So that's something else you can ask your patients about.
And here's a question related to the mechanism. What evidence supports a direct mechanistic effect of NK1 receptor antagonism on sleep regulation, independent of improvements in vasomotor symptoms?
An excellent question. There are studies where one injected substance P into, this was actually a study in men, and they showed that it potentiated wakefulness. So what the neurokinin targeted therapy, elinzanetant, does is it blocks that signal. So that's an example of a human demonstration. I presented work at the Menopause Society. It has not been peer-reviewed, showing that when you look at the benefit in the OASIS trials for elinzanetant on sleep, half of the effect appears to be mediated by vasomotor symptoms and half not. So that is, we need to have that subject to peer-reviewed. It's very close to being submitted. Who knows, maybe we'll submit it to Maturitas, but at any rate, that too is suggestive. But again, I'll say that is not yet past peer review.
Yeah, but do you think that sleep disturbances should be included in the vasomotor syndrome?
You know, it's interesting that you say that. The COMA consortium that said what are the most important aspects of vasomotor symptoms to ask routinely in clinical trials and in research studies added vasomotor symptom related sleep disturbance as a key criterion, because now we look at frequency and severity, but we don't look at sleep disruption. So, you know, that's an example of how I think it really should be. But again, we have to get around this idea that it's all due to hot flashes, because, you know, 75% of the time spent awake was independent of hot flashes in that polysomnography study.
Päivi,
The problem is that there are also women who do not recognize hot flashes, but they wake. And we have seen in those where we research autonomic nervous system that there is a the heat heartbeat acceleration as a shown of sympathetic nervous system failure, and during the night of sleep we should have parasympathetic nervous as a predominant, and of course, they can be connected with vasomotor symptoms, but they can also, those marks can be the first sign that there's something in our temperature regulation center failure, which the woman does not really feel as a vasomotor symptom. And so, on the other hand, in these neurokinin receptor inhibitors, I think this inhibitor 3 may be more important than 1 because it affects more in this preoptic area. And so it would be interesting to see how affected it would be in men, in males, and especially those who has sleep apnea, because they many times present vasomotor symptoms as well. So I think that will be maybe they already examined it, but I wait for those studies as well.
I think we have time for a last question, so I pick a more general one. Does the preservation of the circadian rhythm, night versus day shift work, matter, and how? Who would like to start?
It's very important because we have this chronobiological regulation, and especially those who make night shifts, or so they all the time their system is destroyed. And the most important to have, if you have shifts, to go in front, not backwards, so that that the adaptation system will better cope. So we are not made for shift work. We should have a regular work, and we also should follow the same sleep pattern when we are in leisure time or in holiday or weekends. And so that's very difficult, I have to say, especially for this kind of person as me, who is very, very evening type. So who likes to work until 2 in a night or something. And so this is totally disaster for society. But what can one do?
Pauline, would you like to make a final comment on that?
Shift work is one of the strongest predictors of cognitive dysfunction related to sleep disruption. And, it's interesting when you think about the circadian rhythm of core body temperature. So our hot flashes follow a diurnal variation along with our core body temperature. And when you get that asynchronous effect with sleep, it can be highly disruptive. And, every cell has its own chronobiology. You can extract these cells and put them in their own culture, and they still keep a daily rhythm. And I think that tells us how critical these circadian rhythms are to our biology.
Okay, unfortunately, we have come to the end. So I would like to thank the two speakers for excellent presentations, and also the audience for all questions and comments. And I just wish you to see you soon again. And thank you very, very much.
Thank you, everyone.
Bye.
Bye.